everyone to the final meeting of year 23-24 of the Health and Social Care Committee. How time flies as we move onwards. Stephen, do we have any apologies?
Yes, we've got apologies from Joanne McCoy, Ron Gunn, Mary Wiley and Fiona Malcolm.
Thank you. Just to remind everyone that the meeting is being recorded and will be available on the NHS Highland website, just so as you are aware. And if you could raise your hand to speak as normal rather than using the chat function, which we can't guarantee to pick up. So I'll move on. Ask any declarations of interest in relation to any item on the agenda. Nope, I'm not seeing any hands, so we'll move on to the draft assurance report from our meeting on the 17th of January. We don't have an action plan arising from that. I think there was maybe one item which we missed out of that, but we had been very efficient in closing down all the actions brought forward. So maybe first of all, we'll look at the assurance report for any matters of accuracy that anyone wishes to raise. I'm not going to run through all of the pages individually, but I will just allow anyone a moment to raise their hand in the air if there's anything that they want to pick up in relation to accuracy. Nope, I'm not seeing anything. So are people content that we accept that assurance report as a true record of our meeting on the 17th of January? Seen some thumbs up. Thank you very much. Any matters arising that anyone would want to raise out of that minute, which we are not going to pick up subsequently on the agenda? I've got one item which I'll maybe just ask Simon and or Pam or Claire if she's in the room to give us an update on. No, I'm not seeing anyone else. I'm going to ask Pam, maybe if I just hand it to you and you can pick up from members of your team as appropriate. I thought it might be useful if we just got an update on where we are on the whole care governance. I know there's been really excellent progress made, Pam, but it might be useful if we could just capture that in the minute in terms of the process that is existing. And I think there is still particularly when we had the discussion in the context of the quality review at our last meeting in terms of how we're getting that professional social care input into that as well. So maybe two different aspects of the same sort of issue there, Pam.
Thanks, Jerry. Yes, we have been progressing the care governance. I think within the organisation we've managed to align clinical and care governance within the partnership, just in terms of having our quality and patient safety, just making sure that we're looking more broadly across it at care. We've got an event coming up which does reflect a kind of joint approach to care governance, but again we're still looking through a bit of a clinical lens. Most of the terminology used in the board is still clinical governance. We've not moved to clinical and care governance at a strategic level, and our Chief Social Work Officer is still not assured that we have the right level of care governance in place. And in fact, Fiona's here just now, she can articulate that. And in fact, Simon's still here as well. So in terms of professionally and in terms of statutory responsibility, then I'll ask Simon and then Fiona to come in turn and just give us an update from their perspectives. Thank you. Simon.
Thanks very much, Pam. The good news for me, certainly, Jerry, is that the assurance that the committee can take is that the day-to-day operational oversight in areas such as DATEX, significant incidents, significant adverse incidents, etc., all of those things that you would want to make sure were in place with regard to social work and social care governance are now very much joined up through the through the lens of the patient and person quality and safety activity that takes place within the health and social care partnership. And I would give you my assurance as a social work professional that that I am certainly of the belief that we are appropriately engaged and involved in that activity and able to make such reports as are required. So that's the positive bit. I think the next question would be twofold. One is, how does that then feed into the board level clinical governance, which remains a largely clinical setting? And then the second would be, in more general terms, how does that fit with the discourse that is required in terms of discharge of statutory functions, as that relates to the council's statutory functions that we discharge on their behalf. And I would pass to Fiona Duncan there as the Chief Social Work Officer to describe her position with regard to those higher levels. But in terms of the bit that we were directly controlling within the Health and Social Care Partnership, I would give assurance to the committee that certainly I'm satisfied there's been significant movement in that area.
Thank you, Simon. Fiona, is there anything you would like to bring to the attention of the committee in terms of that professional social work input?
Yeah, I would agree with what Simon's just said. There has been progress in terms of practice and oversight of that. The Clinical and Care Governance Board is not a clear Clinical and Care Governance Board. It's because it doesn't look at care, and it's not about tagging care on. You know, if you're going to have, I understand that is a huge beast, you know, and I appreciate that, but there is that bit where if you want, the problem that you've got by the right people not being there and reporting in is the board can get a skewed understanding of what they think is going on, and they may feel that they're not being assured, but that's because the people that could give them assurance aren't actually linked into that. So that's a conversation, a very live conversation about how do you move that forward, because it's not simply about, well, let's just invite and let's just add. You have to look at the totality and go, what do you need to achieve and how are you trying to achieve it? So, thank you.
Thank you, Fiona. Anne.
So I suppose that's my next question then, is what is it considered that we need to achieve to satisfy the Chief Social Worker's concerns, and what are the next steps in the discussions that have been ongoing to make sure that we can get to that place or some other satisfactory conclusion to these discussions? Thank you.
Yeah, that's clearly the next question. Louise, have you got a similar point, or are you going to attempt to answer the question for us?
No attempt to answer it, to be fair, because I think it's not necessarily a question that I can answer right now, because the work is going on in the background, if you like. But I suppose for me, the key bit, as we understand, is having the right people in the room and making sure that we have clinical and care governance, because the last thing we want equally is just to go down a route where we've got clinical governance and care governance and the two don't meet, because our services meet all the time. So it is understanding, if we were starting from ground zero, what would clinical and care governance look like, and getting us to that point. And I suppose that's what Anne's asking, and I'm not going to try and articulate how we get from A to B, but I think that is key, that we don't risk going down a route of just clinical governance in one place, care governance in the other, and they're never the twain shall meet.
And I suppose it's just following up on Anne's point, and I totally appreciate that we do not have the answer today. I suppose it's maybe just getting an understanding, if we can today, so we can capture it in the record, in terms of what at least is the journey that we're undertaking, in terms of, so we eventually have an end point of achieving that. Pam.
Thanks. So from my perspective, we're quite joined up operationally within the partnership. So, you know, in terms of our quality and person safety, we've really embraced the Vincent framework. We've aligned care governance. We've got representation, and as Simon articulated, around care homes, etc. And you know, DTEXs, and making sure that the adult care staff are you know, working and engaging in that way, and that we can see that explicitly. I think it's more at the board committee where we keep referring to clinical governance committee, and we don't have the right representation of that care staff more broadly around that table, and we're not going to be taking the assurance around the care elements. We may take reports from the Health and Social Care Partnership, but the explicit assurance to the board clinical governance committee, I think that's maybe an area where we need to articulate it more strongly. Thanks.
Thank you, Pam. I'll bring in Louise.
Thanks. I think Anne's hand was up before mine, but somehow we managed to swap. So I'll
swapped,
go ahead.
yeah.
And you're right, I think it is about saying, if we start from scratch, what would it look like, rather than trying to do a tag on to what we've got. However, we have got another part of the organisation, so we've got Argyll and Bute that have got a very established clinical and care governance. We've got other areas of the country, and I know we're different because we're a lead agency, but clinical and care governance shouldn't be that different to do. So it is looking outward as to how it works effectively in other places, and then completely redesigning what we've got, whether that's through a workshop between the existing people or the people that have been that need to be involved from a care point of view. I think we just need to sit down and get that written out and agreed.
Okay, thank you. Anne, I'll give you a final comment on this.
Well, I suppose I was just wondering whether there was already a view as to whether it is going to be possible to revise the terms of reference of the existing Clinical and Care Governance Committee, adjust the membership of it, identify any additional reporting other than the exception reports that we get already, which include care issues from the Health and Social Care Partnership, or whether we're thinking that we require a completely different model of operation of governance here. Is there already a sense as to whether or not, you know, which one of those it is that we're thinking about?
Yes, I think it's a good question, isn't it? Is it an amendment to what we already have, or is it a complete refresh and start again? I think that's a good question, and I'm not going to ask anyone to try and attempt to answer it today. What I will do, and we can capture this in a minute, Stephen. We've got a committee chairs meeting, I think, in a week or so. I will maybe email the chair of the Clinical Governance Committee, and I'll email Sarah, the chair, and actually say, can we have a discussion about that? And I have no doubt they will both take their guidance from the EDG members who are picking up on that, because I think it's something that we just need to flag up, and we just need to establish what the roadmap to the solution is, whether it be as you say, whether it's a complete refresh or it's an amendment too. But the important thing is we get something there, and I think Louise makes a good point. We've got what appears to be a functioning Clinical and Care Governance Committee in Argyll and Bute, so it should not be beyond us to actually come up with an acceptable solution which actually provides the appropriate governance and assurance to the board, because that's actually what we're talking about here. Because actually I'm much reassured that we're hearing that actually at an operational level we're now feeding into the Clinical and Governance Committee, and this time last year we were probably not as assured as we would like to have been, and we've made good progress on that. So thank you very much everyone for those discussions. Any other matters arising anyone wanted to pick up? I was conscious there's an issue on the enhanced services, but they're covered in Pam's report, so I think we'll just leave that until we get to that point in the agenda. So if there is no other matters arising, we'll move on to the continued thorny issue of finance, and I will invite Francis to give us an update on where we are at month end. Francis is here instead of Elaine today, just to so that Francis can bring us the good news of the pot of money she's found in the way in.
If only. Okay, I'm just going to share month 10 slides. Hopefully you see them okay. Can you see those? Yeah, perfect. Okay. So month 10 position actually isn't much different from month 8 that we reported back in January. It doesn't seem to be moving down. Okay, so the first slide is showing where we'd planned, I suppose, our position at the start of the year with the Scottish Government, and I suppose our closing position is, has improved from the start of the year, and that's mainly down to additional allocations that we had in, as well as our recovery programme. So for the board as a whole, for month 10, we were reporting a 50 million overspend, moving to a 39 million. So there has been an improvement in month 10. We've had additional allocations from Scottish Government, which has helped us to reduce our forecast. So for the partnership in itself, we're remaining at just under 15 million. So there's just been a slight change there, and I've got slides further down. So the key risks and mitigations that we've identified early in the year, they've stabilised, some have materialised, some are still continuing. I think really the main thing is that additional allocation that we got from Scottish Government last month, which enabled us to improve our position. So for the partnership, our year-to-date is showing just over 13 million, moving to just under 15 million. Again, our drivers remain the same. We have supplementary staffing, we have slippage against the SIP of just over 6 million. And also we have our prescribing pressure of 2.3 million. So the slide just, actually the table that's on here is showing our year-to-date supplementary spend, which has been a slowdown. It is showing 20 million for our year-to-date. So for North Highland communities, we're forecasting just under 8 million from a year-to-date position of 6 million. Again, we have our pressures from unfunded services, mainly within chronic pain and our enhanced community services. We have supplementary spend, in particular our in-house care homes. That's now increased to just over 1.5 million. And we've also got slippage against the SIP. For mental health services, we have seen a slight deterioration, namely due to increased agency costs, as well as some out of area costs as well to the year end. So we're moving to just over 6 million deficit. Primary care, we have seen again a deterioration, namely due to prescribing figures that we've got now up to September. However, we do have some underspends within primary care that is helping to mitigate the position, namely in our dental service, as we have a high number of vacancies in our clinics. So adult social care has now moved to just under 3.5 million overspend. We do have unachieved savings of 2.7 million, which has been built into the forecast. And we had a discussion last month about there were plans that were brought forward to the council, but because they didn't come into force, that's been part of the slippage there. We've also got the expenditure in the care homes, namely on supplementary spend. So whilst we're forecasting the 3.5 million, we are as a board assuming that we're going to get some funding from the Highland Council for 21-22 allocation, and we're also in discussion with the council in having that, I suppose, that shared risk on the position. So in terms of our cost improvement, our target of 11 million, we are now showing just over 7 million of slippage. So some of the schemes that we identified early in the year, they haven't come into fruition. And that kind of really, namely around the locum and agency costs, what we'd hope to see quite significant kind of slowdown. Whilst we have seen reductions, it's not the level that we had expected. And the final slide is just, I suppose, the assurance of our progress, kind of showing the different work streams and where we are in terms of the partnership, just showing the 7 million of unachieved savings against the plan. So I suppose this is where we are for month 10. We're working on the plan for 24-25. As we reported last month, it's flat cash in terms of uplift. And once we're clearer on, I suppose, our savings target for the partnership, we'll be able to share that. Okay.
Thank you, Frances. Although the overall position remains as challenging, I think we taking our comfort where we can find it. I think the fact that we've stabilised over the last few months, I think, seems to be a key message in there. And I suppose the question that probably immediately comes out of that, where would you gauge your level of confidence in achieving that forecast outturn? I think it's just 14.96 million at month
think
10, I
that-
would expect there to be a fairly high degree of confidence there.
Yeah, absolutely. You know, we're looking at the ledger for month 11, and I'm not seeing any surprises. I think where we actually may see some benefits is through the financial controls that we now have in place. We've seen a slowdown in some of the non-pay spend. So if anything, we'll either stabilise at the 15 million or we'll reduce slightly.
Thank you. And Pam, without delving too deeply into it, because I know there's conversations going on at all levels, where are we in terms of 23-24 support from the council and the likelihood or not?
So we were just at the Highland Council this morning. So they have said that they're going to give us 20 million in reserves, against which we've to develop a redesign plan for 24-25. And actually that would be like a 3-year programme, recognising that we won't just redesign in a year. We are, however, expected to save 12.6 million in efficiencies in the next year, and that's going to be very challenging for us. We did have the opportunity to set out with the council this morning, you know, how we currently spend, what currently costs us, and how services are currently provided, and what we would have to do to reduce, you know, within a resource envelope, and what type of decisions we would have to take. So Simon was presenting this morning, and Fiona Duncan was also there as Chief Social Work Officer. So we're in that active space of looking at what that looks like. What I would say is we're very late to agree the budget going forward. I think the board still has the board will still have concerns, and we need to set that out for the board. Just in terms of the risk to the quantum, really, in terms of the financial settlement that we've had against that, and how the government will view that. So we'll need to have a conversation with the board about what that looks like. So going forward, a very challenging set of circumstances against which to deliver, you know, across all services in health, across all services in the council. The council have got their own set out financial plan. One key area of opportunity is where they can actually assist us with some of this, you know, in terms of, in the board we've got health planners, so we've asked the council to help us with some expertise around commissioning, around some cost and capacity planning that we haven't been able to maybe get to as expertly as we could. And also there's other people that we can work with in the council to help us benchmark with other services, possibly in an area where that will help us understand our spend and how we apply our resources going forward. So that's the kind of headlines from the meeting with the council this morning. There's an opportunity to take much more of this discussion to the Joint Monitoring Committee, really to appraise them perhaps in a way that maybe there wasn't the opportunity to at the council meeting. You know, to bring the Joint Monitoring Committee into focus about how we spend our money, what the impact of these financial savings will be going forward. And of course, we were also outlining the impact to our whole services, if you like, you know, where we may, because of government policy, be spending in one area more than another, managing young people through transitions who don't transition. You know, learning disability people, you know, may not transition in a way that a child with physical health conditions may. So we've got lots to look at around those types of services, and really looking at how much we spend on our older population and how equitable that might be, and you know, really letting the Joint Monitoring Committee see how the resources are set out and the difficult decisions that we may have to take going forward. So we'll be setting that out for them in the March meeting. I think it's the last week in March when we get there.
Thank you, Pam. I think it's worthwhile just capturing for the minute, Stephen, just through a combination of circumstances, not least the timing of the Scottish Government budget and then the Highland Council budget, I think was only discussed at full council last week. We're probably a few weeks behind where we would like to be in terms of looking at 25, although we probably know that the broad parameters of where we sit, and indeed the board are still to have real in-depth discussions about the draft plan, which will be getting submitted to the Scottish Government over the next week or so. So I think it's just important to capture that context for 24-25, that there is still some uncertainty in terms of where we will be sitting as a partnership in terms of available resources next year, and where that may well sit. But I'll throw open to any questions anyone has in relation to 23-24 or indeed 24-25. Neil.
Oh, really, as a comment more than, excuse me, I'm a bit squeaky of throat. As a comment more than anything else, which I have mentioned before, I'm just noting the pressures, or quote pressures, of chronic pain service and enhanced community services. And we're going to come on to Tim's report, which mentions alternative or new developmental strategies for chronic pain. I have a lot of patients with chronic pain, and that service is a really, really useful and good service. And I think it's a shame that its funding is not, as far as I'm aware, is being reduced. And again, as Pam has said, if you're looking at one area and not as another, it's difficult to quantify the benefits. I mean, there are definitely going to be health benefits, but in terms of financial benefits, you won't necessarily see them, because you won't see the reduced referrals or the reduced time in clinic. That's chronic pain. I was under the impression that Enhanced Community Services project in Inverness was a really big good news story. And given our strategy of trying to keep people out of hospital and at home as far as possible, enhanced community services would surely be something we want to support and push. And I just think in some ways it's a shame that it comes up as a pressure. I appreciate it is a financial pressure. That's the way we look at things. But maybe some pressures are good ones to keep on the table.
I think that there's a really important message in there, Neil, in terms of just how we set things out. I mean, Francis is absolutely right in terms of a pure financial pressure, but we have to make sure that we don't lose sight of the service benefits that come along with these, although ultimately we will undoubtedly, as a board, have to make decisions over service benefit versus financial. But I think you're absolutely right there. I see Diane has her hand up.
Yes, thank you for that. I just have a more general question, I guess, as a new member of the committee, which is clearly in 24-5, we're going to have to make some very challenging and difficult strategic decisions about services and staffing and all of those other things. So my question is, and I recognise that the budget is not yet clear enough, when will the committee be presented with the information about proposals for, I suppose, living within our means in 24-25?
Next meeting.
Pam, could I bat that one over to you? What your rough timeline is at the moment?
Yes, of course. So I think we can be, we're looking at that now. We've been looking at that with the council in terms of, I attend the corporate management team, so I've been involved in looking at the overall council expenditure in their areas and focusing on some of the needs we have for social care. So just following on from the outline I gave earlier, then we should be able to bring that to an update and a plan forward for the next committee meeting. We need to start this early.
Yes.
If we keep delivering care at the rate we're delivering, we're going to lose any savings, that we're going to make at the start of the year. So that plan needs to be in place and should be articulated really quickly. We need some support from the council to enable us to do that, though.
Yeah.
Okay.
So but just before I bring Anne in, Diane, so I think our next meeting, I think, is May the 8th. So I would certainly have an expectation that May the 8th, Pam and or Francis, Elaine would be bringing to us a really good, maybe not complete, given it will still be fairly in the year, but a fairly substantially complete outline of the changes we'd be looking to make over what sort of timeline, because I think Pam makes the point here that we're not going to have a list that comes to the required amount of money in 1 year. It's just not going to be.
Yeah.
That's how we're going to achieve that sustainable financial position as well as a sustainable service delivery position over the course of the next 3 to 5 years, I think, is going to be the challenge. Anne.
Thanks for that.
Thanks, Jerry. Pam, I wasn't sure. I don't think in terms of what you were saying about the position with discussions with the council, you mentioned the situation for this year's pressure. So maybe you could pick that up. But I think one of the key things that we need to bear in mind is that whilst the finances are front and centre, a lot of the reason why the finances are front and centre is because of the workforce challenges that we face, and because many of our services are simply unsustainable, given that we are unable to recruit to positions that we have. And as you'll see from the report, that drives a lot of the financial situation. So one of the key planks of the board's approach as a whole to the situation that we're in, Pam, is a revised approach to our integrated service planning for the coming year, which will drive the annual delivery plan that will be submitted to the government shortly, and the board will be meeting in committee shortly to consider that alongside the financial picture. I wondered if you could give us any sort of idea about opportunities, or we know plenty challenges, any opportunities or indications of, you know, where we might need to focus our service redesign efforts from the process that has gone on within the Community Directorate for for the with the integrated service planning approach that we've taken this year.
Thanks, Anne. Yes, so we've been doing work around integrated service planning. So we're understanding our spend a bit better. We're understanding our capacity. Lorraine has been leading on the integrated service planning with Gareth and with Highland as well, so that we're really looking at the finance and our workforce challenges as well, and thinking about redesign. So we've got that all set out. It needs a bit of a professional check just before we sign it off, and underpins what we're doing in terms of our ADP submission. So we've got our Home is Best plan set out, and we really need to focus in on the areas of in terms of the integrated service planning and looking at our structure within our districts. What does that actually look like in terms of how can we replicate management teams and stretch services 9 different times across 9 different districts? So that's going to need a discussion with our local populations as well, just around, if workforces are available, how do we horizontally integrate? How do we merge across districts to be able to make the best use of resources, and bring the community and our citizens into those discussions, so that they're part of looking at solutions and understanding why we maybe can't deliver services, not just because of affordability, but mostly because of workforce. And also the way in which we commission services need to change. So we need to move away from a lot of our expensive in-house provision in terms of care at home, for example, or how we commission with the third sector in terms of getting best value. So we need to make improvements in those areas, so that we can release more capacity within our contracts, particularly for care at home. But during the last year, one of the reasons why we couldn't meet our savings target was because of supplementary staffing. you know, we have a care home that's exclusively staffed with agency staff, and with that comes, you know, quality and safety and people's experience of care impact, and also, you know, the collapse of the independent sector, the issues and financial pressures and funding and charity raising that the third sector are experiencing are also impacting on us in terms of the need for sustainability payments. So we're doing a lot of discussion around commissioning, around reducing and ring fencing and trying to match up resource with demand around what we're actually commissioning with the third sector. So those are some of the key things that we're looking at initially, and that might force us to look at how our services are designed, how our structure is designed in Highland, how we can actually make sure that we've got safe and equitable services across Highland, and we may have to take difficult decisions around, you know, say for example, and only for example, where last year we looked at our care homes that had less than 10 beds, because that's very difficult for the sector to sustain in terms of the national care home contract. They fed that back to us. They've really lived that experience. You know, it may be that we have to think about, you know, where we've said we'll provide care closer to home, maybe we're going to have to get into a different discussion about people having to travel further for services. Or you may have been brought up in Gairloch, for example, all of your life, but you're going to have to maybe spend your latter years in a care home, you know, in another district if that has to be the case. Just in terms of where we can maximise the benefits of workforce and affordability, and of course work with the market, because the independent care market are kind of changing their model. You know, they're wanting to provide more like residential care. They're maybe moving away from nursing care, A, because of complexity, and B, because, you know, that they've proven over time that they can't actually staff it and source it themselves. So, you know, again, we've got a collaborative care home group which has our sector colleagues round about it. So our joint co-production of solutions is going to be really important, you know, working with partners as well as working with communities and citizens to understand where we need to go. And that's all outlined in the direction of travel within the joint strategic plan. So that's really the lever and the document that we kind of frame up with people. But nonetheless, challenging discussions and lots of engagement to be taken going forward to get us into those spaces.
Thank you, Pam. Anne, anything you want to come back on?
There's lots of other people waiting to come in, Jerry, so I'll defer.
I suspect all of these points are going to be linked, so I'll maybe just run round the room and let everyone bring their points in, and we can maybe pick them up at the end. Louise.
Thanks, yes, and I'll just add a little bit to what Pam was just saying, rather than the point I was going to make, and then I'll do that, which is, again, when we're talking about care closer to home, I think we've got to understand and decide what we think is reasonable as a remote and rural board, because ultimately we could just say, okay, let's just have all the services in Inverness, Fort William and Nairn, but that's not reasonable when we're in a board that provides a service for such an enormous part of Scotland. So we have to understand what's reasonable, but also to set out the challenges very clearly, both locally and nationally, so that there's an understanding at national level that providing services in these type of areas comes at a bigger cost, and a bigger cost that we don't at the moment sufficiently have the financials to resource in the way that we would want to, even if we can with the people. Because I get that there's the balance. We could be throwing all the money in the world and it doesn't necessarily mean we'd be able to recruit the people that we wanted to in those areas. And I suppose it was just wanted to reference the fact that we are still waiting for certainly at least one allocation of care home monies from the Scottish Government for the Care Home Collaborative, which sits as a risk at the moment for the board as the route in for the money. So there is something about it's really difficult to plan when we're this far into March and we still don't 100% know what our financial envelope is going to be and what we want to do with it.
No, good point there, Louise. Kay.
Yeah, just a general point on staffing and things. I think that, you know, as far as care homes are concerned. I think there needs to be maybe some red flags about, you know, if there's a care home where there's people off work or whatever, and you know, sort of that needs to be highlighted early on, and almost a SWAT team in there to see what's going on and why are people not choosing to work there. You know, there's reasons why people aren't choosing to work at certain homes or do certain jobs. I don't know. I think there's maybe an opportunity for staff development. You know, the care home sector and things like that. You know, if it was seen as a route to, you know, you start at the band 2, you progress to band 3. You know, and that's sort of like a career rather than just something that somebody does for some extra money. You know, so there's lots of creative things that can be done like that. And care at home, a lot of it is split shifts. I mean, I'm sorry, but you know, who would want to work 7 o'clock in the morning till 10 o'clock at night? You know, with a bit of time in the afternoon, and there's very few people, you know, with family commitments who could commit to that amount of time out of their day. You know, so there's creative things to be done to improve things as far as staff are concerned, you know.
No, I think that's true, Key, as it is with most things. There will be opportunities hidden away in here somewhere. Muriel.
Thank you, Jerry. Thanks, everybody. I've got a few observations. Do we have any data on enablement for people that we have been able to support staying in their own homes? Because I think we need to look at that. Obviously, we've got, I hate to use the word crisis, but some of it is a crisis. And the other thing was it was mentioned that there's a care home purely running an agency staff. That, in my opinion, is not sustainable. So what are we looking at in that area? Where's the, you know, how are we going to deal with that? Because it's not a solution, and it's certainly not a solution for the clients at all. And I think we also need to be in the front foot for managing communications. We're all very aware of some of the communications that are around just now. And I think we need to be careful in language. We will obviously be doing as a team, both council and the health board, working to deliver care as close as we can, but whatever the models are. But I really think, why are we still using all agency in a home? You know, why have we not looked at an alternative model there?
Yeah, I think that's that's a fair comment. I'll maybe not ask Pam or Louise to come in that at the moment. David.
Yeah, thank you. I mean, I just wanted to reflect a wee bit on the adult social care strategy recently finalised, and that recognises that, you know, too many people go into care too soon and for too long in Highland, and that we need to change that balance, and that's about helping people to live better for longer, really independently. And I'm not hearing much about that just now. I'm not expecting this quick bit of the meeting, but until we change that balance, you know, we know that we can't build enough residential homes or nursing homes or anything else, regardless of place. So it's really important that part of the focus as we're going forward is that whole much bigger question about living better at home, and that can be all kinds of things, and that will actually help to free up resources, because if people are living independently, they don't need to be in residential care, or they don't need to be in nursing care as early, and it's that balance that we're needing to change, and that's not going to be easy. That's why we've got a 3-year plan. But you know, I just wanted to make sure that we keep a focus on that. Thank you.
Thank you very much, David. I think that's really important, as you say. Just it's important we use the agreed joint strategy and actually to drive forward the changes that we're talking about. I think what I'm going to suggest, rather than asking Pam or Louise to go around all those individual points, there was obviously a common themes there, and I'm conscious that in our work plan for the next committee meeting, it should be the care home collaborative report and the care at home annual reports. And I would suggest maybe we just pick up and tease out a few of those issues at our next committee meeting. It'll give us actually the chance to actually think about this. And I think we can pick up the points as well that Muriel has raised there in terms of a potential enablement data and what is our strategy, if we have one, where we've got and what we would know is an over dependency on agency staff, because I think there's always a level of agency staff which we will always have, but there comes a point where we say, well, we've got an over dependency on agency staff. So I think that there's lots to think about there, and I think for me it's really good that we actually start thinking about how we use the future reports to the committee in terms of actually to inform some of these discussions, and actually how we actually get them all to tie together, rather than it just being a very simple assurance report. This is actually how it's tying into where we need to go forward. So if we revert back to the paper, Francis's paper, we've been asked to discuss and note the Highland HSCP financial position at month 10, associated actions, and accept limited assurance. Are we content to do so? I will deliberately stay away from the word happy. Thank you very much indeed. We will so record that in the minute. We're now moving on to one of the highlights of the year. Tim has joined us as he very frequently does, and although this topic is titled the annual public health report, and that will be the frame that Tim chooses to take into to take us through his presentation, I think this is really just I would appreciate just a general overall discussion about public health and how we're recognising that, particularly in terms of addressing inequalities, picking up Neil's points about chronic pain and enhanced community services, and how we're actually factoring that into our service delivery and our service design moving forward. But I will not steal any of Tim's thunder, and I will hand over to Tim. And I know it says 2 o'clock in the agenda, Tim, but please, I think our agenda allows you to go on and present to us. Thank you.
Thanks very much, Jerry. I think it'll depend on the questions. I'll try and get through the presentation reasonably swiftly, and it's really there to highlight the particular elements of the report. Just to start off with an apologies to those members of the board who've already seen the presentation, and also apologies to elected members of the council who will see the presentation again next week when I come to Highland Council. I've already been to the Argyll and Bute Integration Joint Board as well, and the report is a report for the whole of NHS Highland. But just as it has issues for Argyll and Bute IJB, it has issues pretty much the same for Highland Health and Social Care Partnership. One thing to mention is that most of the issues and the statistics presented relate to the whole of NHS Highland, but by and large they're fairly similar for Highland HSCP. I shall show presentation. So I hope that you can all see the presentation. You have some, yeah, excellent. Okay, I was have to say I was rather surprised to realise that this is my 4th annual report for NHS Highland. I've done a fair few before then elsewhere, and they do tend to change a little bit in content. They always include a degree of epidemiology and pointing out the health of the local population and what our particular challenges are for overall health. In the days of, I think the first one I ever did was about 20 years ago, and about that time, and also I'm not the only person in the meeting today who's done these reports. So in the days that Councillor Burt used to do the reports, I think they were more directed towards a wider focus on epidemiology. Nowadays, a lot of the epidemiology and a lot of the information and health statistics is available online, and we've got the profiles for localities, which is available on the NHS Highland website, which obviates the need to a certain extent to include detailed statistics within the report. However, it's really important to stress the crucial elements and the highlights, or perhaps lowlights, of health in the local area. And then what's been the trend, and I think is a good thing to focus on within the reports in recent years, is to look at a one specific focus. And the focus that I chose for this year is public health and medication, and both the good and the bad elements of that. So first of all, I've got a few slides on epidemiology, and then I'll move on to the particular theme or medication. Okay, so first of all, just a slide on life expectancy. Again, bearing in mind this is NHS Highland as a whole. This illustrates two things. The further you go on to the right from, well, it illustrates three things. One is something we take for granted, which is an interesting thing, which is women tend to live longer than men, but often we don't actually talk explicitly about that. Then we also see that as we follow down through the years, there has been an increase in life expectancy, which is well recognised, and then a plateauing, or in some cases a slight fall off in life expectancy over the last few years. Life expectancy itself is a slightly odd statistic. It doesn't represent how long we live. It's how long we would live if the age at death for everybody at the moment was applied to a notional population. So, but it gives an indication of how long people are living. So it's gone up a bit, but then plateaued, fallen off a little bit. But also the one particular thing I would point out on this slide, and as Jerry really highlighted, one of the main issues that we need to think about is health inequalities. So particularly for men, the gap between the life expectancy of the richest and the poorest has grown very considerably, and is now it's probably about 9 years now, whereas it was about 6 years a couple of decades ago. So there's certainly something going on, and lots of reasons for that. But health inequalities, if anything, are getting worse rather than getting better. Now that comes to overall life expectancy. We can also look at healthy life expectancy, how long people live in reasonably good health. When we compare ourselves with Scotland as a whole for the board, we don't do too badly. Even so, the length of time that people in Highland are living in poor health is not great, but it's very considerably worse when we look at inequalities, and people who are poor can be living 25 years, up to 30 years on average in poor health. So that's something we really need to address. And the causes of this are various. This is sort of underlying disease causes. Somebody asked in the presentation why obesity is not down, but it's if we're doing the list differently, things like obesity would be down, but we're not looking at underlying causes. It's more classifications of diseases. So it's a whole range of things, but heart disease, lung cancer, depression, dementia is also high up there, but and again these will be affected by inequalities, but also a lot of these will be amenable to elements of prevention, which picks up some of the themes from my report last year, particularly things like ischemic heart disease, cardiovascular disease, lung cancer certainly, very amenable to reduction in smoking, but also changes in diet and exercise. Dementia less so, but there are certainly things that we can do around dementia prevention. Going back to inequalities, it's all well and good looking at the individual areas, but when we look at specifics, the picture becomes even more stark. So this is sort of death rate. So the previous chart, it was life expectancy. So lower down the chart was worse, but here's going up is worse because it's on death rate. So in common with pretty much all conditions, the poor die earlier. Also young people tend to have higher death rates. We've got early deaths from coronary heart disease, death age 15 to 44. There's a very significant worse picture for the poor. Then if we look at the bottom two charts, two areas that are of particular concern within the Highland HSCP, deaths from suicide, where we have a rate which is considerably higher than the Scottish average. We see that disproportionately affects the poor. And drug-related deaths, where we are doing a little better than the national average, but it's still a huge issue locally. That is really stark, not just the increase, but the increase among the poor. So the overall message here is around the importance of being able to tackle health inequalities, that targeting work and the various different efforts that we can put into looking to reduce the gap in outcomes. So I'll move on now to the particular focus of the report for this year on medication. Now, initially, my idea was to focus the report and to try and get something more catchy. And so I was going to entitle the report The Good, the Bad and the Ugly, and then link up different bits of the medication and public health to the good, the bad and the ugly. Against my better judgment, the public health staff persuaded me that was style over substance. I renamed it after another film, Do the Right Thing, the Spike Lee film. However, I can't resist still putting up that from the famous spaghetti western, and I think there is some value, if only in memorability, in looking at issues of the good, the bad, and the ugly, alternatives, and also synthesis, what we can do, and the overall message really, which is encapsulated far better within the report and what other people have written within the report. Than I'll do in this presentation, is to realise that there are good things around medication and public health. Lots of medication does a good job, and sometimes we don't recognise that. But also there are times when medication isn't the right thing, or there are alternatives. Some people will do better on medication, some people will do better on alternatives, some people will do better on both. And to look at how we can synthesise these together. So there are 5 different themes: environment, hepatitis C, social prescribing, prescriptions, pain, and one particular case study. This is no way meant to be comprehensive. It's just meant to show examples. So the first one on hepatitis C is an example, both to incorporate health protection within the report, but also to emphasise something that maybe not too well known about. Hepatitis C tends to be a bit of a Cinderella disease, and it's hidden in the both hidden from the headlines and also hidden in that many people will be carrying the hepatitis C virus but not know about it. And it's important to get more for people who may be at risk to get treated. But if people fear the effective treatment, then and the consequence of having a positive diagnosis on their lives, they may be less reluctant, they will be less reluctant to come forward for testing. But the good news is there is a new oral medication available, which is far more effective than the old interferon style treatments, which were not particularly effective, needed to be injected and took a very long time. Medication has moved on for hepatitis C, very effective. And so that will encourage people to come, or should encourage people to come forward. And so the message for this section is we've got good medication, We want to encourage people to come forward for hepatitis C testing. That will enable most of them to have the virus eliminated. And in line with the rest of Scotland, we are hoping to move on to eliminate hepatitis C within the communities. The next section's on pharmaceuticals, pharmaceuticals in the environment rather, and it builds on, and the chapter is written by Sharon Flager, a consultant in pharmaceutical public health, who is nationally and internationally renowned for her work on medication and the environment. And I won't go into any more detail than that, and it's all that is set out within the report. But there are a lot of potential risks of medication going into the environment, and also potential benefits from additional controls on what we can do to reduce the burdens of pharmaceuticals in the environment on overall health and well-being, and for example, stopping medication getting into the food chain. The next chapter is on medication and medication for pain, and the potential for that to a medication used for pain to be used for other things, and to either get onto the black market or to be continued to be used longer than would be appropriate. This is an area that hasn't had very much local investigation yet, and really I've included it within the report in order to get a stimulus for further work in the area of alternatives to chronic medication for pain. It may be appropriate for some people, but often for musculoskeletal pain, the use of opiates, and particularly the use of benzodiazepines, which fortunately have gone down more, has been in many people going on for years and years. And after a short time, it really becomes not particularly effective, and other strategies can be used to manage pain, as Neil alluded to earlier. We haven't got the detail to go in the report into the volumes of medication used in this way, but there are other things in the report which demonstrate the underlying problem, including here the chart of drug-related deaths. This is NHS Highland as a whole. We tend to, in Highland HSCP, tend to have a bit more higher proportion of drug-related deaths. We're still a little bit below the national average, and the latest figures, which haven't been published yet, do suggest it has plateaued somewhat. Linked to the idea of alternatives to medication is social prescribing, which is also covered in last year's report. The term itself is a little bit of a medical model, but essentially it's about alternatives to prescribing and what we can do to improve people's health using different referral mechanisms and pointing people to other ways to support their health and well-being. Again, we go into quite a lot more detail within the report, and within Highland there's been the opportunity to expand the primary care social prescribing service, which is welcome, but I think there's a lot more that we can do to support social prescribing. Oh, I forgot to mention these. The bottom one on the social prescribing slide is also, there's a chapter on this, just examples and case studies to look at how it's possible to how it would be most desirable in the great many cases to manage for people to manage their long-term conditions using a combination of medication and also other interventions such as you get from social prescribing. So there are a whole load of recommendations as ever within the report, and you'll be pleased to know I won't be going through them one by one. The reports generally are there as a stimulus for action, setting out various recommendations, and then it is for the organisations, whether the health and social care partnerships or the board or the local authorities or other agencies, to consider recommendations and then to consider how they may wish to take them forward. So I think that will do for the presentation, and I shall stop sharing and open to questions.
Tim, thank you very, very much indeed, and no need for apologies. I've seen the presentation at the board, but I enjoyed it even more again today, because there's always something new in it. I will throw us immediately open, but I know Christopher has got another appointment, so I'll maybe bring in Christopher first.
Yes, well, thank you very much, Tim, for that presentation and for a really impressive report. I've been through it online, but I hope I can have a properly printed bound one in due course, so I can study it at length, which it certainly deserves more attention than I've given to it so far. Thank you for all you said. I particularly want to raise the whole issue of cardiovascular disease. I mean, your graph showed the terrible scale of the problem of coronary heart disease deaths, and your paragraphs on page 79 in the report go into more details. A scourge of death, disease, and disability caused by cardiovascular disease. If we think about coronary heart disease in particular, which was the major cause of death of the cardiovascular diseases on your graph, I know people think that I always go on about diet, but diet-related issues are the more than half of the risk factors for coronary heart disease. So we really do have to take diet and what we can do about it seriously. And that is, I fear, more challenging and more difficult for some people to face up to than perhaps we had realized. Until I retired, I was for 2 decades part of the European public health community. But I haven't sort of been with them since I retired, but I did go to the European Public Health Conference in Dublin in November, which was centered around diet, really. And after several years there, I was rather taken aback when my colleagues, as they were freely talking about meat eating as the new tobacco. Well, I realized in the early 1950s, it was pretty shocking to people who smoked to suddenly learn that tobacco smoking caused lung cancer, and a few years later, they realized coronary heart disease. But most people in the 2020s hadn't realized that meat eating was a cause of cancer itself. We've known for years, decades, that vegetarians had a longer life expectancy than meat eaters, but we didn't know why. But we do realize now that meat eating, particularly beef, is a risk factor for colon cancer and pancreatic cancer. That bit didn't surprise me, and I could see the rationale by talking about the new tobacco. But there was one thing that really did shock me. There was a major prospective study in the Netherlands, in and around Breda, over many years, about 15 from what I recall. They had a large population, which they divided into two. The two populations were very well matched in terms of age structure, gender, social class, etc. They told one half to eat meat regularly, and the other half never to eat meat, but to have pulses. Well, the cancer findings were as expected. There was more colon pancreatic cancer in the meat eaters. But the staggering thing was that the coronary heart disease incidence was double that in the meat eaters of those that didn't eat meat. I knew there was a difference, but I didn't know it was going to be that great. So, I mean, most dietary guidelines that we try to apply now, and there are several, they all stress a reduction in meat eating, and that's something we'll have to emphasize increasingly. So I look forward to, and I've said this before, to development of more activities designed to improve diet, particularly of young people, because they've got long lives to live, at least long, if they have healthy diets as children and continue into life. So I look forward, after I've been and gone, no doubt, to see the coronary heart disease death rate falling in Highland, because it's a terrible toll on health and death as things are at present. But thank you, Tim. I look forward to reading it at greater length. It's an excellent report. Thank you.
Can I just come back quickly on that, Joe? Yeah, just to say, yeah, thank you for your comments, and I will endeavour to get you a printed copy. We don't regularly produce the printed copies, but for anybody who requests a printed copy, I'm sure we can get them. In terms of the food, I think the major development that we'll be looking at over the next year or two is the move for a national food strategy, and that has local elements to it. The council is the lead agency, but that's really we've got a really important role within NHS Highland as well. So I think that's an opportunity to both to improve overall food consumption with healthier food, to reduce inequalities, and also to look at potential more local sourcing of food and reducing.
I agree, that was most important. Yes, I agree.
Thank you, Christopher. I've got Kay.
Hi. First of all, just to follow on with what Christopher was saying about nutrition and food. I mean, I think it's coming out now that any ultra-processed food is, even bread that you buy, if you buy brown bread, then if it's ultra-processed, it's really not very good for you compared to what bread used to be like. And ready meals and etc. Even they say they're low fat or whatever, they're then really not good for you. So it comes back to basics, and it comes back to education and cooking. And I mean, that may be why women live longer than men, something like that. That the age group, when I went to school, it was only girls that learned cooking, and we learnt to make profiteroles, and we learnt to make kedgeree at the age of 10, so we were brought up with cooking and now, although they still do cooking at school, I don't think it's to the extent or the specialism that we were expected to have at that age. So, in terms of alternatives to medication, perhaps, that should be thought of as well in terms of learning to cook and make your own food. And the other thing that I found really shocking was the levels of medication in water. It looks like Britain is really high, and it's social or political, because Southern Ireland is a different colour from the rest of Britain. So it's and America's the darker colour from Canada. Even the bit of Alaska that's sticking out. So it's definitely cultural and social rather than just to do with geographical area or centres of population or anything to do with other environmental factors. So that is quite shocking. So need to be look at this prescribing.
Thank you, Kay. Diane.
Can I?
Tim, do you want to come in?
Oh yeah, just to come in particular, that just if I come in it, I won't forget what people have said. Yeah, I think the ultra processed food is another issue, and I have you can find bread in the supermarkets without the additive, but it's very, very difficult. Just to try and make sure we don't there's not too much doom and gloom. Just to highlight one thing in terms of the medication in the environment, and this happened a few years ago, and it's before my time, but it's still through the work of Sharon Flager and her colleagues in other agencies that Caithness General Hospital in Wick was the first hospital in the world to get accreditation under water stewardship for the quality of its effluent water. So I think that does demonstrate that there is good work going on locally, and that does continue. And it is one of the areas, albeit in a small way, that Highland is leading the rest of the world. But even here, we do have a lot more work to do.
Thank you, Tim. Diane.
Thank you, Tim, for an excellent and I suppose very thought-provoking report, which is really good for us to see and focus on. I just wanted to comment that I was really happy to see the emphasis on social prescribing in your report and the importance of that in taking a holistic approach to dealing with health inequalities and also some of the major causes of early death. I remember going to a presentation in Lancashire about 8 years ago from a public health lead who said one of the most important causes of early death in Lancashire is poverty. And that always struck me as a very powerful statement. Social prescribing, which has a focus also on helping people with other problems in their lives, like finance, debt, which is particularly important at the moment, and looking at somebody's life as a whole, rather than only as at their medically reported conditions, is really showing its value now. And I guess what my plea to colleagues on this committee and on the boards is to please not let this then be a victim of spending cuts. I know we have very challenging decisions to make next year, but the return on investment is really beginning to increasingly be proven for social prescribing and holistic approaches. So please let's try to keep that on our agenda, because the benefits are already being seen.
Thank you very much, Diane. Tim, anything you want to add to that?
I think there's nothing specific. I think I certainly agree regarding the poverty, and I think comment, and the slides bear that out, and also around social prescribing, also support for people in general. And one of the challenges is that influences on health are largely, well, the things that influence health most are largely those things like employment, poverty, housing, education. But the links sometimes are hard to make. So I certainly agree with that, and it's I would hope we'll be able to keep work going and increasing on social prescribing, and the evidence is also being increased. There's been a project with UHI looking at the effectiveness of social prescribing in a remote and rural context. So I hope that we'll be able to move that on further.
Thank you, Tim. Anne.
So also thanks, Tim, for a very interesting report. It struck me that there was quite a few potential links in there to work with our primary care colleagues. And I was wondering how, whether it's through the Primary Care Improvement Fund, whether it's through enhanced services, whether it's through just general work that we're doing with primary care, we are trying to make the best use of some of these learnings. Yep. For example, how are our pharmacotherapy staff involved in medicines review? What are we learning about the community link workers' role in enhancing social prescribing? And I'm particularly wondering whether we're actually collecting the data that we would need, that, you know, that would help us target our efforts around social prescribing to best effect. So a broad question I appreciate, but I wonder if anybody has any thoughts on that, either our community services colleagues or yourself, Tim. Or indeed, Neil.
Claire, I can see your hand in the air.
Yeah, so I'll come in as, I suppose, the Deputy Medical Director for that area. I'm just wondering if committee would like to see a bit of a report on that for the next meeting, because it's certainly something the areas you've highlighted on around about the PCIPs, the primary care improvement, about the development of our primary care strategy and charter, all of these things would be incorporated into that. So I wonder if that might be useful to committee for next time, that we could provide a bit more of a detailed response to that. And I would say working with our GP sub colleagues as well, I think that would make a very interesting and thorough read. So it's more of an offer.
I don't know if it would necessarily the next committee, Claire, but we've certainly got a primary care improvement topic on a future agenda. So I think it would make a good topic for Perfect. That. Yeah, yep, it might be July sort of time, but it'll be on the work plan.
Oh, perfect. Well, that's ideal.
Maybe I wonder what if Tim could comment on that data query.
Yeah, I think in terms of the data, yeah, well, it's complicated. It relates to a whole different elements of the report. There certainly is more that we can do with primary care data, and if we look at different elements of the report, they will then have different. There are different aspects of how we look at the primary care data. So if we're looking at one example would be prescription data for chronic pain, and how we can look at what the patterns prescribing is, and how it may be possible to move to alternatives on that prescribing. That's still at a very early stage, and we don't know. We don't know as much as would be desirable about that. In terms of social prescribing, as I said, there's work with UHI going on around evaluation. We tend to base social prescribing, and have certainly in terms of which practices were able to get earlier access to social prescribing and larger access to social prescribing to areas of material deprivation, and to practices in more deprived areas and serving a more deprived population. And that tends to be as good a proxy as anything for ability to, well, for need. Whether it's ability to benefit or not is maybe a slightly different question, but we need to make sure that we target appropriately for tackling inequalities. So yeah, the answer to the question is, should there be more, or would it be better to have more information available? The answer would be yes. But I think we wouldn't want to wait until that information was available to be able to be looking at implementing what we know to be effective, or to be putting some interventions in place, and then those interventions could potentially be modified by what else is available or what we found out from information. And I think as a whole, we don't make enough use of that primary care information, and we could do more. So I think it's going to be an improving picture, but there is a lot more that we can do.
Neil, I think I saw your hand up there.
Yeah, sorry, just to add, yeah, hopefully a bit of a positive spin. Certainly been sort of an uptake in use and function of our pharmacy colleagues. They've been very, very helpful, reviewing patients, etc., and just taking over quite a bit of the work. We have a community link worker, and they are also very useful in basically helping people navigate difficult situations, be that financial and or access to services. I think, and it's very difficult to show outcomes, and that's the nature of the beast. It's difficult, as I've said before in other committees, it's difficult to show negatives. It's difficult to show that people don't go on and need other support, or need to go to hospital, or need to come to see me, or whatever. So it's difficult to show that you've improved something in that way. What we do have is, or what I've seen reported, is plenty of evidence of uptake of use of these services as they've come in. So that's good. One thing I'm thinking of, though, is that they do need, and this goes back to Diane's point, is community link workers, navigators, all of us working in this area need to have places where we can direct people to. So, and that's maybe one of the cruxes in it. You know, if you want to have, for example, exercise programs ongoing at the local leisure centre, so that people don't feel inhibited in using the gym, they can go along and build, buddy up or whatever, then and have an easy way in, then in some ways that's the kind of provision that we need. And I have to say I'm embarrassed to say that I don't actually know what that provision is very locally, but my impression is that it could be improved. Notwithstanding that, there's also, as you say, finances, costs, etc., and we do have some good services locally for that.
Thank you very much, Neil. Diane, I'll perhaps give you a final word on this topic, just in the
It's all right. I don't need the final word, but I just wanted to say that there are in many localities, including Skye and Localsh, where I live, local directories which are produced by lots of, but usually by SLCVO or those sorts of community umbrella organisations, providing directories to people of all the services that are available in their local area. And maybe we need to do more to publicise the availability of that, and to ensure that primary care colleagues in particular know of their existence, because, why would you? And I think maybe that's something that we could also encourage.
Sarah.
You're on mute, Sarah.
Thanks, Anne. Sorry, NHS Highland Community Engagement team are looking at a similar resource within the NHS, so they're linking with that. There is a national piece of software you can use, and they're looking at using that. So there is work afoot to encourage that across the patch.
Thank you, Sarah. Okay, I've not seen any more hands, and although I think we could undoubtedly go on for a great deal longer talking about this, I think we'll draw this item to a close. Tim's report in this discussion is really brought to us for information, and we're asked just to note the annual report and accept substantial assurance. I think it's accepting substantial assurance on the report rather than anything else. But I think it's all. I say to Tim every year, I tremendously enjoy this discussion, and I think the public health discussion just highlights the need for all of our services to. And we're very quick to use the word integrated, but I think this really shows you the need for education, housing, health care, everything to sport and leisure. Everything really needs to come together, and we need to be making all of these decisions in concert and in harmony if possible. And I fully appreciate that that's not always possible. Christopher, I'm aware you're about to probably dash out the door fairly quickly, so I'll let you come in.
Well, it's just the point you were making about accepting substantial assurance. If it's substantial assurance that the Highland population is healthy, I wouldn't accept that at all. It's a very unhealthy population, unfortunately, which we have to deal with. But if we're accepting substantial assurance that this is a high quality report, then I would go along with it. Yes. We have to be quite sure what we're saying is we're giving assurance to.
Yeah, I think we're accepting assurance on the quality of the report, the quality of the underlying data, and the quality of the presentation, and that there is work programmes supporting it. I don't think we're making any other observation other than that, Christopher. Okay, thank you very much indeed, everyone. We were scheduled for a quick comfort break. How does everyone feel about grabbing a quick cup of tea and back in the room in 10 minutes, and we'll go on to the vaccination programme update. So I shall see you back. Well, I'll take 2 minutes off of you. I'll see you back at 14:40.
Okay, thanks,
Thank
Jerry.
you.